First speaker is our host, Dr. Nandini Menon. Dr. Manu could not make it to the conference, and she'll be speaking to us on Amivantamab plus chemo with or without Lazertinib in EGFR mutated NSCLC.
So good morning, everyone. I'm just filling in for Dr. Manu. And this is the MARIPOSA-2 study that I'm going to discuss in the next maybe 7 to 10 minutes. So we all know that Osimertinib, and now with the new data of FLAURA2, Osimertinib with chemotherapy is considered one of the standard treatment options. But in 2023, the MARIPOSA study also showed an alternative treatment options using Amivantamab, which is a bispecific monoclonal antibody targeting EGFR and MET in combination with a third generation TKI called Lazertinib. Now we all know that once you fail on Osimertinib in second line setting, we in the past didn't have good drugs in this space, and this was the study which evaluated what happens to patients who progress on Osimertinib and how do they benefit with this regimen. So we, as I just mentioned, EGFR and MET alterations are known to be the major causes for resistance to Osimertinib, especially MET amplification. So Amivantamab is a bispecific antibody. It binds to both the EGFR and the MET ligands. It also has multiple other mechanisms, including immune cell directing activity and modulating the immune responses, which add to its advantage. And Lazertinib, like Osimertinib, is a highly CNS penetrant third generation EGFR TKI. So we have data from the Chrysalis in the second line, we have MARIPOSA in the first line, and now we are looking at MARIPOSA-2. So this study was Amivantamab Lazertinib chemotherapy and Amivantamab chemotherapy compared to this control arm of chemotherapy. Now initially when the study was designed, the Amivantamab Lazertinib chemotherapy and then the Amivantamab chemotherapy arm was added actually to look at what components of this triplet or quadruplet regimen was contributing, but eventually they modified it to allow dual primary endpoints, that is to look at comparison of Amivantamab Lazertinib chemotherapy versus chemotherapy and chemotherapy as a control and Amivantamab chemotherapy versus chemotherapy. So they tested both these new combinations with chemotherapy having a dual primary checkpoint. So this was the primary endpoint of the study. This was the same MARIPOSA-2 which was presented in 2023, and I'll be presenting its another update. And this was published in 2024 in Annals of Oncology. These were the inclusion-exclusion criteria. So advanced metastatic EGFR-mutant NSCLC with the standard EGFR mutations, exon 19 deletion or L858R. The key criteria is they should have progressed on Osimertinib as the most recent line, either in the first line or the second line. Fit patients of PS 0 to 1. This study allowed brain mets if they were stable and adequately treated. Unstable, untreated brain mets were not taken, but stable brain mets were allowed. And these were the stratification factors. At what line they took Osimertinib, race, and presence of brain mets. So the regimen included Amivantamab at 1400 milligrams weekly for the first 4 weeks, and then 1750 every 3 weeks, which was the Amivantamab group. Lazertinib is an oral tablet. It was given at 240 milligrams. Now, initially in this arm, everything was clubbed together and all were given concurrently. But they realized that Lazertinib and chemotherapy toxicities, especially hematological, were cumulative. So they then modified it to have Lazertinib sequentially. So some of the patients in this study, in the Amivantamab Lazertinib chemotherapy arm, received Lazertinib sequentially. So these were the baseline characteristics, well balanced, especially for the key stratification factors, including the brain mets and race and other things, and including for the type of EGFR mutation. Now we look at the results. So first we look at the objective response rates, and as you can see, in the second or third line EGFR post-EGFR therapy, in the EGFR mutant lung cancer post-Osimertinib failure, the combination of these drugs, that is Amivantamab Lazertinib with chemotherapy or Amivantamab plus chemotherapy, had a remarkable objective response rate of around 64% in the second or third line setting, whereas chemotherapy only gave a objective response rate of 36%. So the primary endpoint was blinded central review of these the responses, and if you look at it, both Amivantamab and Lazertinib did better than chemotherapy. So these were dual primary endpoints. So Amivantamab, Lazertinib and chemotherapy combination, the quadruplet, of course, had a better PFS of 8.3 months. The Amivantamab chemotherapy had a 6.3 month PFS, and chemotherapy alone was 4.2. This was something similar to the investigator assessed PFS. The only difference was when the investigators assessed, they had a similar PFS for the Amivantamab chemo and the Amivantamab Lazertinib chemo arm. So again, what I wanted to highlight is all the subgroups that they stratified for, including brain mets, which is one of the important prognostic factors, the type of mutation, what line patient received osimertinib, race, gender, age, all categories showed that when you added amivantamab to chemotherapy or you added amivantamab lazertinib to chemotherapy, definitely there was a benefit. Now the important thing what I want to highlight in this MARIPOSA-2 study is the intracranial effect. Now when they designed the study, amivantamab was thought that it's a monoclonal antibody, does not cross the blood-brain barrier, and that was a rationale of adding a CNS penetrant drug such as lazertinib to have intracranial activity. But what you can see in this Kaplan-Meier is the intracranial progression survival with amivantamab chemotherapy and amivantamab lazertinib chemotherapy was similar. So which even the investigators proposed that the probable reason, which is not what they thought when they designed the study, but the probable reason is amivantamab, despite not probably physically crossing the blood-brain barrier, may be having effects with immune modulation, other mechanisms other than directly targeting the EGFR and MET and having an intracranial control rate comparable to the group where amivantamab and lazertinib was combined with chemotherapy. Again, they did a sensitivity analysis to look at whether radiation was the reason for these patients not progressing. So they had a group of people who had received radiotherapy and they had included, and those who did not receive radiotherapy. And even in the group of patients who had no prior brain RT, there was this consistent benefit seen, which goes to say that using amivantamab in combination with lazertinib and chemo, or amivantamab plus chemo alone, that itself controls CNS disease, irrespective of whether the patient had received radiotherapy or not. So this was what was the early interim overall survival. They seem to be a trend, but it is not significant, and that was what was published. This is the adverse event. We know amivantamab has significant toxicities, and like Lakhan had discussed, subcute amivantamab to decrease the toxicity rate because infusion reactions leading to issues in more than 50% of patients, and a lot of skin toxicities which are an issue. So that was what was the concern. What otherwise was seen was none of the toxicities led to death, but there were some discontinuations of treatment in all these arms. And you know, the more you combine, the more we expect toxicities to add and to discontinue treatment. So if you look at the quadruplet arm, there was around 10% who had to discontinue because of toxicity. So consistent PFS benefit across all groups, higher objective response rate, longer duration of response, good intracranial PFS, excluding the fact, I mean, even if you take into consideration for the fact of patients who have received radiotherapy, at the first presentation when this paper was published, interim OS, we did not know whether it was significant or not. They seem to be a trend. Of course, because of the hematological AEs and the combination of amivantamab, lazertinib and chemotherapy having more neutropenia, they modified it. And when they presented the first data, there was a significant number. Nearly half had received sequential lazertinib after completing the pemetrexed carboplatin regimen. So that's what we need to keep in mind. The second abstract or the presentation is a small second interim overall survival analysis of the same study. Now this focused on amivantamab plus chemotherapy versus chemotherapy. And because they got that trend when they did the initial analysis that there might be a benefit in OS, so they looked at further a second interim analysis to look at the OS benefit when the data matured, whether it really was there. So again, if you look at this is a longer follow-up. And this was at 18 months landmark analysis, and you can see 50% of those who received amivantamab plus chemotherapy, we are not discussing the lazertinib arm here, and compared to 40% of patients who received chemotherapy were alive at 18 months. Again, the time to treatment discontinuation was longer with the combination of amivantamab chemotherapy, time to developing a symptomatic progression was longer, and time to subsequent therapy was longer. So basically, amivantamab plus chemotherapy, when you compare to chemotherapy alone, seem to have better outcomes. And this trend to overall survival seems to be sustained. We need to see for a longer follow-up for its final impact. Here the hazard ratio was 0.73 and it was statistically significant, but probably a longer follow-up we also need to see what happens over time. Now this is a diagram, I don't want anyone to get confused. What this bar graph shows is the number of patients who receive various therapies after failure on MARIPOSA-2. That means in the third or fourth line setting in EGFR mutated lung cancer who progressed on osimertinib and then progressed on the MARIPOSA-2 regimens. So in AMI chemo and the chemo arm. And what they showed is that of course fewer patients had fewer patients progressed, so that is different. But patients in the third line setting, often we tend to re-expose them to previously used therapies, and what they wanted to show is that if you want to get a better survival, you should maximize the outcome in the second line setting. So if the patient has failed on first line osimertinib, give him the best treatment in the second line, because subsequently we may not have effective therapy. So to conclude both the abstracts, this was the conclusion of the second interim analysis, that MARIPOSA-2 is still ongoing, final OS is pending, but whatever they found on the second interim analysis for the Amivantamab chemo arm versus chemotherapy, there was improvement in the time to symptomatic progression, time to treatment discontinuation, subsequent time to subsequent therapy, and maybe the trend to OS was sustained. So probably it's a signal that that might be a promising OS trend, and you may have a positive OS outcome also. So what it overall shows is that Amivantamab plus chemotherapy or Amivantamab Lazertinib plus chemotherapy, despite the toxicity, definitely has a role in the second line or third line setting after progression on osimertinib. In all parameters, including progression-free survival, time to subsequent treatment, CNS disease control. The challenge is what happens to OS, whether it will be significant, and considering the toxicities, especially cutaneous and infusion reaction, what is the quality of life? So just to summarize, this is one of the regimens which has in a randomized study shown to be effective in the post-osimertinib space. We talked about the subgroups that benefited. We also talked about its CNS activity, even if you excluded lazertinib, and even in patients who had not received radiotherapy for brain mets. After modification and making lazertinib sequential, the quadruplet regimen seemed to be better tolerable, but yes, toxicity is a concern, and we still need some data on the liquid biopsy and the ctDNA in this setting. So with this, I'll conclude, and thank you for the patient hearing.
Thank you, Nandini.